Hello and welcome to the 72nd World Health Assembly.
I'm Vismita Gupta-Smith and I work for the World Health Organization. We're coming to you live from Geneva, Switzerland. The 72nd World Health Assembly opened yesterday. Delegates from 194 countries came in and were all present at the opening. Policymakers, health ministers, public health experts, and global media. You're watching some shots from the opening ceremony. And the speeches at the opening ceremony focused on universal health coverage. So on today's show, we'll also focus on universal health coverage. The idea that everyone, everywhere should have access to quality, affordable health coverage without going into financial ruin or suffering financial hardship. Now, WHO has set itself an ambitious target of benefiting an additional 1 billion people with universal health coverage by 2023. And of course, we cannot do that without our partnerships and our partners. So we have an impressive lineup of our partners today here on our show, and we want you to be involved. So ask us your questions. If you put your questions on our timeline, for our experts, we'll get you the answers. On today's show, we have Dr. Seth Berkeley, Chief Executive Officer of Gavi, the Vaccine Alliance. Welcome, Dr. Berkeley.
Thank you.
We'll also have Dr. Lola Dare, President of CHESTRAD, a civil society organization. Ms. Natasha Mwansa from Zambia, a youth health advocate. Dr. Matshidiso Moeti, WHO's Regional Director from the Africa region. So don't forget to send us your questions. I want to start today's show with an excerpt, Dr. Berkeley, from yesterday's opening ceremony. And on this, I want to play you an excerpt of Dr. Tedros' speech.
The world has made great progress towards universal health coverage. The Declaration of Astana, endorsed by all 194 member states last year, was a vital affirmation that there will be no WHA without primary health care. Primary health care is where the battle for human health is won or lost. Primary health care is at the heart of Immunization Agenda 2030, our new strategic initiative, which we're designing with you to maximize the power of vaccines. Because we cannot achieve health for all without vaccines for all. Just last month, we celebrated a historic milestone in the fight against one of the world's ancient diseases, with the launch of the world's first malaria vaccine in Malawi and Ghana, which is being rolled out based on recommendations from WHO's Strategic Advisory Group of Experts on Immunization. Last year, WHO responded to 481 emergencies and potential emergencies in 141 countries. Ebola does not take sides. It's the enemy of everybody. But we're not just fighting a virus. We're fighting insecurity. We're fighting violence. We're fighting misinformation. We're fighting mistrust. And we're fighting the politicization of an outbreak.
That was Dr. Tedros talking about universal health coverage in his opening speech. You just heard him say that there can be no universal health coverage without access to universal access to vaccines. So I want to talk about some of the very important moments this year about vaccines, but let me get your reactions to that first, Dr. Seth.
Well, first of all, thank you for having me. And second, of course, he's absolutely right. Vaccines are the most cost-effective health intervention. For every dollar invested, you get a return of around $18 unless you take into account the effects of full life lived, and then it's $1 to $44. So if you want to be able to afford universal health coverage, you need to have prevention, you need to have vaccines fully rolled out.
We want to talk more about that. We're already getting some questions from our audiences for you. But first, I want to talk about a very important moment, the launch of the very first malaria vaccine in Malawi, and a week later in Ghana this year. And this pilot program, which aims to reach 360,000 children every year, is also expected to be launched soon in Kenya. Now, malaria kills one child in every 2 minutes. We are seeing some shots from the Malawi launch of the vaccine. And most of these shots, these deaths happen in Africa. And this vaccine, the RTSS vaccine, has been 30 years in the making and has been shown to reduce the number of times a child gets sick with malaria, including life-threatening severe malaria. So before we talk about that, let's take a look at little Lordina's story. Lordina is one of the first babies who was vaccinated in Ghana.
Now, mendene da anajuna ne ho ado ne ho ye tututututu nti me sole na masensuo na me de tawra bonsom na me de apepa ne ho nyina kopem se ne ho badwo nti ya na se ne ho sanso ye hia na masanso aye timenda mintumenda metekata so saa nti adechi a na miniska na makobo besia na me de nka na me de ne ko hospital nti aya sa akrampo no sika me didi me dwane na sai aya sa na maya basa na me yahia enye na akwala na medwen no ho se obenya apomedin na me so masoma adwum na metumi aye adwuma wo se me ye basa metumi yahwe me nkwala ya mo ofie kura me nya kwan no aduane ma omko na omo adi me ni jesu say me so mepe ni say me de so say mo impenifu a mo nya adura mo de bebo mo ho ban nti mepe say o mo bebo no ho ban o mo bewo ne panye na abo no ho ban a me mre na metumi aye me adwuma na mabo me bra na masuma adwuma.
That was the story of little Lordina, one of the first children vaccinated in this pilot program, which was the financing for which was organized through the collaboration with Gavi, the Vaccine Alliance, the Global Fund to fight AIDS, tuberculosis, and malaria, and UNITAID. WHO coordinated this pilot program and provided in-kind contributions with our partners like PATH and GSK. So, Dr. Seth, tell us, what was that moment like? We know a lot of people were very emotional to see the first child vaccinated in this trial against malaria.
Well, first of all, malaria is a terrible problem, and we need new tools because of drug resistance, insecticide resistance. So how do we bring new tools forward? This vaccine has a long time in the making, as you already said. But this is not a rollout of the vaccine. This vaccine has gone through rigorous testing. It went through a phase 3 efficacy trial and received a positive review from the EMA of the European Union. The challenge is that this vaccine requires 4 doses, and 3 of them are outside of the normal intervals for vaccines. So this is a trial to ask the question, can we implement this vaccine? Will we get the highest coverage we need to be able to do that? Will it be accepted by parents? And in the modeling for the trial suggested that for every child every 200 children that are vaccinated, you would save 1 life. We want to see in a real life situation if that's really how good it really is.
Thank you for that clarification, very important, and yet it was, of course, a very big moment for researchers, for public health experts, and our partners, all of us, all of the organizations that worked so hard for this moment. I want to take some audience questions, Dr. Berkeley. Vignesh Thiru wants to know, how do you think health for all will be accomplished when most parts of the world are in severe economic, environmental, and agrarian crisis?
So I think the most important thing as we think about trying to bring universality to health is something we call progressive universalism. So, and what that means is you start off providing the interventions that can make the most difference, that have the greatest effects, that are most cost effective, and as you have more financial resources, then you add on to that. And what's really important about health is it's not an expenditure, it's an investment, because when you make communities healthy, when kids can learn, go to school, become productive members of society, then that builds the economy up, and therefore every country needs to be investing in the health of their populations.
So your Gavi, the Vaccine Alliance, has actually been investing in strengthening primary health care. Talk to us about that approach, please.
So vaccines are the most distributed of all of the universal health coverage tracer interventions for the SDGs. Right now, about 85% of kids are vaccinated. If you take the first dose of DPT-3, it's 91%. So it's widely distributed. Of course, that means that 15% or 9%, depending on which number you use, don't have access. And in some countries, it's much larger. So what we try to do is invest on bringing this fundamental and most cost-effective intervention to those communities. Because vaccines don't deliver themselves. If you do that, you bring a health worker, you bring a supply chain, you bring a data system, you bring a cold chain, and that is the building block for primary health care. And ultimately what we want is every community in the world to have access to primary health care.
So, Dr. Berkeley, I'm seeing a lot of questions on, is health for all achievable? People want to know, is this a realistic goal?
Well, what's important to understand is that out of the 200 essential health interventions, 90% of them can be delivered through the primary healthcare system. So that's why progressive universalism is such an important idea, because you can work with a country given their resources, and obviously some of those resources can be supplemented by external resources, but to put in place the basic systems to improve the health. And then as more money is available, you add on to that and add to the complexity to build a completely strong public health system.
So, Dr. Berkeley, talk to us about innovation and universal health coverage, and especially vaccines.
So one of the challenges in reaching these unreached is more and more they're in urban slums, they're people who have been affected by climate change, they're in refugees, and so if we do the same things we used to do, we won't get the results we need. So we need to innovate. And in doing innovation, we're working with the private sector to bring new innovation. So for example, one of the things we've worked with recently is using drones to deliver vaccines as well as to bring safe blood. And this is a really exciting intervention, because in Rwanda, for example, the entire country is served now by drone, which means 20 minutes you can get blood. So if a woman comes in hemorrhaging, you can have the blood that is right for her on site, and if she needs more, you can bring more, which has brought wastage to zero. So these types of technologies, using digital technologies, new ways of learning, can really make a difference to bring healthcare to the population.
We're seeing some shots of drones delivering vaccines in Rwanda. And drones have been used to deliver also essential medicines to populations who are harder to reach.
Well, what's exciting about this now is that Ghana has taken the lesson from Rwanda and is now rolling out across a much larger country to 2,000 health centers, 24-hour a day, and it's not for routine deliveries, but this means anytime there's a stock out or a problem, you need an essential drug, it can be delivered there. So we're going to see how it begins to work at much larger scale.
Well, Dr. Berkeley, we know you have a very packed schedule, so we thank you for taking the time to join us today.
Thank you for having me.
Sure. Thank you very much. You just heard Dr. Seth Berkeley talk about a whole host of issues, including the need for strengthening primary health care. So primary health care being that set of values, principles, and approaches aimed at improving people's health, it's also an approach that recognizes that many of the causes of ill health lie beyond the health sector. And therefore, we have to take a whole of society approach and not the narrow medical model. To unpack this a little more, we spoke earlier to Dr. Lola Dare, president of CHESTRAD, a civil society organization. Now, Dr. Dare and her team work to improve health access to women, children, and communities in Africa. Let's take a listen. Dr. Dare, speak to us about the role that primary health care would play in providing health for all.
Primary health care is fundamental. Since Alma Ata, primary health care has been presented and implemented by almost every African country as the foundation of national health systems building. So it's very timely for us to transition or to integrate UHC and primary health care and connect the dots.
Right, and when we do connect the dots, what will change in people's experience? How will people experience healthcare differently when primary healthcare successfully transitions to universal health coverage?
Okay, I like the use of the word successfully transitioned because at the moment they are not experiencing that success. They're experiencing fragmented services, and so you would have some people have TB services because the Global Fund is active there, but they don't have malaria services or they don't have maternal care services, and so at the moment what they experience is a very fragmented kind of service. Our vision, our hope is that when we effectively integrate into UHC, every facility at the primary level would be able to offer an agreed package of essential health services. These essential health services should be country determined and country owned, and it should respond to the priority burdens at country level. We also need to communicate, we'll be communicating appropriate utilization. What you don't expect at primary care level in a health center should not be there. And so we expect immunization should be at primary care level, and surgical kidney replacement cannot happen at primary care level, and that would happen at specialist care level.
Dr. Dare, for primary health care to play such a central role in delivering health for all, we have to empower our health workers. Speak to us about the challenges that they're facing on the ground.
When we worked with the Global Health Workforce Alliance a couple of years ago, and we did a health worker motivation survey, it was a learning curve for even us as advocates that the greatest motivation is not your salary. The greatest motivation is finding something to work with, going to a facility and finding a bedpan. The nurses want a bedpan. If they don't have bedpans, how do they work? If they don't have syringes, they don't have gloves, they don't have water, they don't have power. And 62% of the workforce were frustrated by the lack of things to work with, even when they know what to do. I think that's the biggest constraint they have. The biggest constraint they have is not having drugs and supplies and not being able to do what they know how to do to save lives.
Dr. Dare, at the World Health Assembly, WHO and partners and member states will be discussing some of these ground realities. How do you see decisions made at the World Health Assembly here this week impacting the beneficiaries on the ground and the people that you serve?
I'm going to address myself this time to our African policymakers. It's very important to be part of the global community, but they should not forget to always bring their own reality and their own perspective to inform important debates such as the WHO debates. Financing of healthcare is an important thing. We need to ensure that domestic resources inflate to finance healthcare. We would expect them to come back from that debate, recognizing that our health systems are varied, our financial economic capacities are varied, and that we need to develop homegrown financing processes. The debates we're having at the global level should not only be the global talking to us, but also the global listening to us.
Dr. Dare, thank you very much for joining us.
Thank you very much for having me.
Okay, so you just heard Dr. Lola Dare talk about her expectations from the World Health Assembly. Speaking of which, speaking of expectations, we have a youth health advocate, Natasha Mwansa. Welcome, Natasha.
Here.
Natasha was here at the World Health Assembly's opening ceremony and spoke to all the delegates and talked to us about her expectations as a young person. So Natasha, you just turned 18, did you?
Yes, I just did on the 3rd of May.
You're already a very accomplished young lady. You're a first-year mass communication student at the Zambia University, and Jamia is the university I studied in. So I did my mass communications before you were born,
Yeah.
probably. A youth representative for the United Nations Population Fund in Zambia. You're already a very passionate advocate. So tell us, what are your expectations from the World Health Assembly?
Well, some of my expectations from the assembly are honestly, firstly, to see that young people's health is prioritized in every possible way. I love that people have been making pledges towards health and what they'll be doing when they go back to their countries. And I think it's very important and vital that we hear what they are actually going to do for us, the young people, back home in their countries. So it's very important that, one, we stand out. They do mention what they promise and pledge to do, and that we increase their promises, like things like budgetary allocations, for instances. They're talking about all these policy formulations, they're talking about this and that. So all that has to go towards young people's health. And then secondly, I'm expecting the gender gap to reduce, because women in leadership when it comes to health is not something that we hear of a lot. And I think that has to be dealt with, because we find that most of the people who are ignorant or who are health illiterate are women. And women are the ones who actually have more power to ensure that health literacy goes worldwide and that people are actually healthy in communities. So I do believe that female empowerment has to be emphasized, and we have to see that more women in leadership when it comes to health is going to be achieved. And then thirdly, I want to see us to have an integrated system. I want them to realize that it's not just about the health sector alone, it's about everyone playing their role. So I want that to come to a conclusive remark and say, look, what is everyone going to do to ensure that we achieve universal health coverage? Because we can't leave this alone to policymakers, we can't leave this alone to politicians, it's every individual out there. So those are some of the key things that I would really love to get out of this assembly.
I'm glad that your generation's not leaving it up to us. Clearly, we are not doing very well in delivering on many fronts like climate change. Tell me, when you have conversations with your peers, do you find that they are as motivated to be involved, or what are those conversations like for 17, 18-year-olds?
Well, the thing is, it really does depend on the situation and the place where you're talking to them from. For instance, where I work in different facilities, and I work with young people generally. And at first, of course, when you interact with them, because they don't know how important it is, you won't expect them to be as passionate as I am or any other person who's health literate. But then the more they get this information, the more they realize that, wait, it's not a privilege, it's actually your right. You deserve this. This is owed to you. They actually have to demand for it. And so the more they get to realize that, the more enlightened they are, the more information they're able to gain from us as we educate them and all that, the more we share, the more it becomes a safe space, the more they take it more seriously. And so right now, I've been doing this for 3 years now, and in the first year it was, so laid down, everyone was reluctant, but then right now they even hold us ourselves accountable. So it does really depend. If the person is informed about such situations and they realize how vital it is, they do take it passionately. But then if they are not informed, or it's just one of those, the government will take care of it, then they won't be as passionate. So I really do think the missing link is just health literacy. The more people know, the more they realize how important it is, the more they realize that it is a right and it is owed to them, the more they'll demand, and the more engaged and active they will be and will participate in ensuring that we achieve universal health coverage. So it's really just depends on how much they know.
So Natasha, I want to talk to you about how your peers, the youth of today, see the work that our organizations are doing. I'm going to ask our cameraman to pan to the values charter behind us. This is the WHO Values Charter, which talks about our values. Do you find that young people today, that this resonates with the young people and their expectations? I'll read the values for you. We are trusted to serve public health at all times as professionals. We are committed to excellence in health. We're persons of integrity, people working in WHO. These are our values. We're collaborative colleagues and partners, and we are people who care about people, so all our actions are focused on that. Do you see these values, do you think these are values that speak to the expectations of young people?
Well, I do love the last one about people caring about other people, or rather the World Health Organization caring, because we live in a world where young people will not be motivated to do much if they don't feel loved for, if they don't feel cared for, and that's why we've got a lot of issues where there's anxiety going, a lot of mental health, a lot of this and that, and it's all deteriorating because one thing that people just want to know is that someone out there is there to take care of them. And so I do think, one, when they are cared for, it is something that they resonate with, and it is an expectation on its own because we need to be taken care of. That's how health works. And I love the point on integrity, because integrity is when you do the right thing because it is the right thing to do. And we know that one of the reasons why universal health coverage hasn't been achieved yet is things like corruption, things like political, rivalry, all those issues that are going around it because of one simple thing going wrong, because one person just decided not to have integrity. So I think those are very important. And yes, trusted to serve public health. It is very important because young people are part of the public, and so if we trust them to be able to serve us the way they ought to be serving us, then of course it is something that they should do. And professional, I think it's very important that they do stick to being professional. One of the main issues that come out with young people is I can't really go to a health facility because the nurses will treat me like they're my mom. And so it becomes a stigma issue, and they're not treated with respect as human beings, but instead they're looked at as people who shouldn't be doing certain things, and that's wrong. So I do believe that that has to be put into practice. And collaboration is very important because we cannot do anything alone. We won't be able to achieve anything of meaning alone. So collaboration is very important. So I do think these key values are very important, and they do resonate with what young people deserve and expect.
Great. Well, stay with us. We want to talk a little more about universal health coverage. Now, delivering universal health coverage and health for all in low-resource settings has its own challenges. Gets more difficult in emergencies, but actually delivering health care where there's violence and our health workers and health facilities become targets of violence is even more difficult. WHO sadly lost an epidemiologist. Our colleague, Dr. Valery Mouzoko Kiboung, was killed in an attack on Butembo University Hospital. Dr. Richard was deployed to respond to the Ebola outbreak in Democratic Republic of Congo. He's one of many WHO staffs killed over the years. In fact, he's one of the many health workers, experts, vaccinators, hospital staff who have lost their lives in the line of duty. Dr. Richard's family is here, and we're honored, and we paid a tribute to our colleague at the opening of the World Health Assembly. Let's take a look at this short video put together by his colleagues.
Grandir à ses côtés, ça a été pour moi une formation morale, intellectuelle de tout temps.
Il est mort au combat parce qu'il était en train de faire ce qui lui plaisait, disponible pour les autres, prêt à secourir ceux qui en avaient le plus besoin.
He was compassionate towards others and was an integral team player. Richard will be sorely missed here at the WHO.
Dr. Richard, WHO will not forget you. You will remain for us all an example, a hero, and a light for future generations. Goodbye, my brother. Rest in peace.
That was our colleague, Dr. Richard. I have here with me Dr. Matshidiso Moeti, WHO's Regional Director for the Africa region. Dr. Moeti, speak to us about Dr. Richard and what losing a health worker, a dedicated epidemiologist, a WHO colleague, what does it do to our response when our health facilities and health workers and experts are attacked?
Yes, thank you. I'd like to talk about Richard in two senses. One, as this tremendous, skilled, big-hearted public health expert who gave his life, which is a tragedy not only for us in WHO, but for his family and his country, and particularly for this response. Richard was coordinating a sub-team in Butembo and taking a lot of responsibility for coordinating the work that they were doing, going into the community, surveillance, etc. Losing him, and I think the brutal way in which he gave his life, the impact on the team, on his colleagues, first of all, they were heartbroken. They were discouraged. They were frightened. They had to stop working. We, in our duty of care, had to ask them to stop working. I think for the response more broadly, it increases the risk for the local community considerably, because it meant that we couldn't go and follow up contacts. We couldn't start vaccination in time for people who had been contacts not to be protected, not to be infected. We could not do the work of initiating treatment, the work of ensuring that families who were deceased managed the burial safely. And I believe that it breaks the trust between the response and the community. So it was a very negative event, had a very negative impact on our response. It teaches us, though, that we must find other ways to establish the trust with these communities, to understand what it is that they're objecting to adjust, which is what we're doing, our response. I'd just like to make a quick reference, because I did have the occasion with the Director General to attend Richard's burial in Cameroon. And there I found somebody who was at the center of his family. Not only his family, his church, he was religious, his community. We were able to see how all sorts of people appreciated and loved him. His family. His mother said he was the father of all sorts of children who were not his biological children in the family. His nieces gave testament of his loving nature. His friends, his ex-school friends, of all socio-economic status, there was somebody who clearly had not progressed in school to the extent of Richard, spoke to him so warmly today. So he was a tremendous, rounded person that we've lost.
Indeed, it was a very emotional moment for all of us here in WHO. And speaking of trust and maintaining communities of the community's trust, that is actually built during peacetime, during routine work, and your team on the ground works with our partners, with governments to establish and to strengthen those health systems. So let's speak to us a little more about our work in strengthening health systems, so that when there is emergencies and these situations, we already have resilient systems.
Yes, it's absolutely vital, and we've learned a lot over the years. We learned a huge amount from the Ebola outbreak in West Africa about these two, the links, the inextricable links between a resilient, well-functioning health system and the capacity to reduce and manage outbreaks and public health emergencies. For example, the work that we are doing every day in countries as WHO spans from the central level, helping ministers and their teams to develop national health policies that are based on our evidence, strategies of how to implement this, coordinate and manage the partners so that we have a coherent contribution of international support to what these countries are doing, right down to the district level, where we play an important role as WHO in ensuring that districts are functioning. We provide training for district managers in a number of countries. We help the governments to establish a team around the district health leader, a multidisciplinary team of nurses and other people, and most importantly, increasingly, in our quest to help countries achieve universal health coverage and improve primary care, we are working very much on what's happening at the most peripheral of health facilities, that interface between the health system, the healthcare workers, and the community. Because we've learned that surveillance, for example, relies on rumors in the community of what is being seen of an unusual pattern. So it's from people themselves and making sure that people have that interface, that contact with the nurses. In most of our countries, frankly, the people who are present at that level, especially in rural areas, are nurses, that they're able to consult them, that they're able to tell them that something abnormal is happening, or that they are able to trust enough to go into the health facility so that the nurses observe a different pattern of illness from what is usual. So our work spans that whole range, and it is very important that that level be functional, because that's the base, if you like, of a resilient health system.
So, Dr. Moeti, we're getting a lot of reactions on our Facebook timeline. I'm going to read a few comments and ask you to respond and react to them. Vikram Pandit says health budgets should be increased by all countries. H.K. Das says political will and stable governments make a lot of difference in health planning and budgetary allocations. And Hamed Gary says Mombasa and Kisumu is a malaria zone. How will we support helping malaria vacations? Well, that's a little bit of a different tone to that question over there. So I'll let you react to some of these questions about the need for increased budget and political will.
Yes, indeed, there's no doubt that if I take the example of African countries, we have seen an increase in health domestic investment, but it's simply not sufficient. So I won't even talk about the 15% of the Abuja Declaration, the commitment that heads of state made some years ago, but the per capita investment in most African countries is not sufficient to deliver a basic package of health services. And we are working with ministers of health to advocate, and parliamentarians increasingly to advocate for increased domestic spending. But just to emphasize, it's not just enough to increase the spending. We need to invest smartly. We need to invest appropriately so that we spend our money where we'll get the most return in terms of improved health and well-being for the populations. And I do believe if we follow the principles of universal health coverage, we'll get huge returns for that investment. So the question about consistency, if you like, of changes of governments, not meaning radical changes of policy which might derail directions in which governments were going to invest in health. Indeed, perhaps we need to accept it is the reality that when one political party leaves, they may change the direction that the country is going in altogether. I have a lot of faith in the consistency of those who stay in the system, even if the political leadership changes. So the leadership on the technical side, and most importantly, the population. The people stay the same. The people's aspirations to have access to healthcare stay the same. So what needs to be consistent is allowing them a place at the table, whoever may be in government. It's important for the population to be able to demonstrate, if you like, to express their need, their demand, their requirement for consistency in the way that the government works with them in order to continue to improve investment, delivery, results to improve people's health.
Dr. Moeti, I believe Natasha has a question for you as well.
Yes, I most definitely do. I think for me, the major question that's been ringing on my mind is we've got all these solutions, and sometimes we do hear them and they're repeated and we know what to do. And of course, the emphasis is important. But then I just want to know, is there that one thing that we're missing out on, all those key things that we're overlooking that could actually help us achieve universal health coverage, especially amongst young people? So the question simply is, what are the key things that maybe are being underlooked and not talked about as much or not acted on that are key to actually achieving universal health coverage if we take them up?
Okay, I think, Natasha, I'd like to share with you, just picking up on something you said in your statement, that, do you know, I used to work for UNICEF in Zambia, and I used to supervise a colleague who started adolescent health services in some of the clinics in Lusaka. So when you said we don't need adolescent health corners, that very much resonated. And I guess we've learned a lot since that time. That was a couple of decades ago. I think one of the elements that gets overlooked, or perhaps that is not supported sufficiently, is the agency of people themselves and the engagement of people and the real impactful involvement of people with a space to not only contribute to dialogue and discussions, but to have their voice listened to have an impact on what happens. And a good example of when a community is engaged, empowered, influential, is what we saw with the HIV response in the HIV community. So what would be very exciting would be this to evolve so that young people have a similar voice. They're able to be at a table. And what did it take? Not that I'm recommending this for action, but these are some examples of what happened. There was a time when certain leaders who were thought to be most influential in influencing investment in HIV/AIDS couldn't get up and speak at a conference without a group called ACT UP jumping up and down, showing posters saying, "You're not doing what you're talking about. We hold you accountable." In order for us to permit you to speak at this conference, we need to be convinced that you go away and do what you talked about. So I think that pressure, that interface between young people and decision makers needs to be facilitated so that it has an impact. And it's our collective responsibility. I recognize very much that it's part of our responsibility. In WHO, we've established an adolescent flagship program, which is in its formative stages, looking at the range of health problems that young people face and the opportunity that young people with their creativity, energy, if I look at you and I see you talking, I see all the possibilities for young people to not only to influence their health today, but to lay the basis for good health and well-being into the future if we can interact with young people in the language you understand, with the messengers that you trust, for us to lay the basis, for example, for healthy lifestyles, to reduce the huge burden, the evolving epidemic of non-communicable diseases today, the sexual and reproductive health problems. So I do think, echoing what you said, what other young people have said to me as I go around, that it's not just for a young person to come to a conference. We need to find space for you to be at the table when decisions were made, in a WHO office, in a UNICEF office, when ideas are being hashed out, so that what you think gets carried not only by your own voice, but others who might have more influence, but that you have the opportunity to make your ideas known to them. I think that's one of the things that we could really work on.
Well, I think you just answered one of the questions on our timeline. Vignesh Thiru, his question was, youth health is a major component in determining a country's productivity, but these plans and targets, which are still it's still a dream, and how can we tackle it? So you just answered that question. I think with the involvement of youth, we want to thank all of you viewers. We have quite a list here. People are tuning in from India, Australia, the United Kingdom, US, Argentina, Philippines, Thailand, Pakistan, Somalia, Ghana, Canada, Jordan, Honduras, Mozambique, the Solomon Islands. It's a long list. I'm going to keep reading so that we can give you a shout out. We have people tuned in from Libya, Mexico, Cameroon, Zambia, Burkina Faso, Italy, Australia, the Philippines, North Macedonia, South Africa, Nigeria, Guyana, Denmark, Mongolia, South Africa, Bhutan, South Sudan, Egypt, Turkey, Somalia, Nigeria, Burundi, Cambodia, Myanmar, Vietnam, Poland, Greece, Iraq, Japan, and Kenya. So that's quite
that's amazing. That's quite a reach.
Well
done to you.
Well, thank you very much for asking your questions from our experts. Keep watching us on all our social media channels. All WHO official social media channels will give you updates from the World Health Assembly. It's goodbye from us for now. Until next time then, bye-bye.